So hello everyone, and thank you so much for the invitation to talk about postoperative monitoring and to discuss why we should monitor patients differently as soon as they leave the PACU and are back on the surgical wards. So before I start, I'd like to just briefly disclose the fact that I'm today leading a consulting and a research company, MICO, based in Switzerland, and where we focus on digital innovations with medical applications. And here are some of the partners we had over the last 7 years. So, as you know better than me, too many patients go to the hospital for surgery and have to stay for complications. We know from this large international surgical outcome study that around 17% of surgical patients develop at least one postoperative complication. It's actually more, 27%. After a major surgery. Because of these postoperative complications, unfortunately, some patients die after surgery, and apparently more people die after surgery than from HIV, tuberculosis, and malaria combined. This is not fake news. The information comes from this paper published in Lancet a few years ago, estimating to 4.2 million the number of people dying worldwide within 30 days of surgery. This is indeed more than the number of deaths attributed to HIV, malaria, and tuberculosis combined. And if it was a disease, that would represent the third leading cause of death on the planet. So many surgical patients develop postoperative complications, and these complications may be detected with a delay, mainly because nurses are spot checking vital signs on an intermittent basis, usually every 4 to 6 or 8 hours. And now we are able to monitor vital signs continuously. We can also quantify what we miss or what we were missing before continuous monitoring. And this is a very interesting study from the Cleveland Clinic, published a few years ago. And they realized that when nurses were spot checking vital signs every 4 hours, they actually missed 82% of hypoxemic events and almost 80% of hypotensive events. Opioids may induce respiratory depression, we all know that, but there is today a consensus to say that no patient should be harmed by opioid-induced respiratory depression. And just to quote Dan Sessler in this editorial published a few years ago in Anesthesiology, it is likely that many catastrophic respiratory events could be prevented if we were monitoring continuously respiratory variables. The nurse-to-patient ratio is very often suboptimal on the wards, on the surgical wards. And you may have seen, like me, this kind of studies reporting that in only 40% of the ward patients, vital parameters are actually monitored as was instructed. And this systematic review published in Surgery now several years ago is also very interesting by demonstrating an inverse relationship between failure to rescue, that is to say deaths related to postoperative complication, and the nurse staffing level. So then we have two options. We can either dramatically increase the number of nurses working on surgical wards. It's unfortunately unlikely to happen. Or we can try to improve the way we monitor patients using new technologies. In-hospital cardiac arrest often occur on the regular wards as well. That's a very interesting audit study done by Jerry Nolan, so done in the UK. They pulled data coming from 144 acute hospitals. And as you can see, 57% of in-hospital cardiac arrest were actually observed on regular wards where patients are monitored only from time to time. So as a matter of fact, patients don't suddenly deteriorate, but we suddenly notice just because of this intermittent spot check. And I think that study from the group of Dan Edelson from Chicago is a good illustration. They quantified the MUSE, so you are very familiar with modified early warning score in the UK. So it's an aggregation of vital signs. So they quantified the MUSE in patients who had a cardiac arrest on the wards and patients who did not have any arrest. And of course, or as you can expect, the MUSE was very different 30 minutes before the arrest, but it was also very different 8 hours before, 24 hours, and even 48 hours before. Actually, a statistically significant difference was already observed, despite the fact that at the time of admission on the wards, I mean, these two groups were absolutely comparable with regard to the Muse score. There is also clearly today a trend towards the admission of older patients with multiple comorbidities on the wards, patients who are obviously at higher risk of clinical deterioration. So another reason to upgrade, to improve the way we monitor patients today on the wards. In addition, overwhelmed ICUs cannot always cope with a surge of acutely ill patients. It became very obvious during the COVID-19 pandemic, and that's why with Bernd Sogel from Germany and Benoît Vallée from France, we propose in the future not only to increase the number of ICU beds available, but also to upgrade the way we monitor patients on the wards using smart, modern, wireless monitoring systems. And that's what I'm going to discuss now, because remote and wireless monitoring solutions are actually available. But before discussing the different options available, I mean, which variable do we really need to monitor? So I think this study is very useful to answer that question. It's a very large study. You see over 400,000 adult patients. In this study, they analyzed abnormal vital signs which triggered rapid response team activations. And you see that there is not a big difference between these vital signs. Rapid response teams are very often activated by a rise in heart rate, a drop in SpO2, a rise in respiratory rate, or a drop in blood pressure. So I think in a perfect world, we would need to monitor these 4 vital signs continuously. So what are now the existing remote and wireless solutions? So there are actually many. For instance, to monitor heart rate continuously, you know, it's not a big deal. You can even do that with your watch today. But if you have in mind medical grade solutions, I mean, you can use electrodes, some are wireless, or adhesive patches to monitor continuously heart rate. This is an editorial Daniel Sessler and I published already 5 years ago. And at that time, you see already many different adhesive patches were approved for medical use to monitor heart rate and one lead ECG continuously. Today, it's probably much more. SpO2 and pulse rate, you know, they are miniaturized wireless pulse oximeters. You maybe have one yourself. I personally have always one with me, particularly when I'm traveling. Anyway, I mean, these miniaturized wireless pulse oximeters were increasingly used during the COVID-19 pandemic, not only for self-monitoring from home, but also for the early detection of clinical deterioration for patients who were on the wards, sometimes receiving oxygen. And of course, when patients are hospitalized, these sensors need to communicate with nurses, need to be able to inform nurses either at a central station or even better on the smartphone or on the pager the nurse is carrying with her or with him. Blood pressure. Blood pressure is actually a variable we are now able to measure continuously, non-invasively, wirelessly. There are 2 main methods which have been proposed so far, the pulse wave transit time or the pulse arrival time method. So to quantify the pulse wave transit time, you need to record the ECG signal, so usually with skin electrodes. And then you need to record at the same time a peripheral wave waveform, so typically from the pulse oximeter. And then from there, you can calculate the pulse wave transit time. And you know there are mathematical models that have been developed to predict, if not blood pressure, at least changes in blood pressure when detecting changes in pulse wave transit time. The pulse decomposition method is another way to compute blood pressure continuously from a finger sensor and using a proprietary algorithm based on reflection waves. Respiratory rate is also a variable very important, if not the most important, because the most sensitive to detect clinical deterioration. You know, respiratory rate may increase not only in patients developing respiratory complications, but also in patients with shock or metabolic acidosis. Unfortunately, it's until today, clearly the neglected vital sign. We know it's very often quickly guesstimated by nurses. And that's why over the last, I would say, 5-10 years, many different methods and techniques have been proposed to improve the way we monitor respiratory rate. So you see on that slide, beside the visual counting by nurses, video monitoring, capnography, piezoelectric sensors that could be placed under the mattress. It's also possible by quantifying the respiratory swings of the pulse oximetry waveform to estimate respiratory rate. We can also use accelerometers that will be sensitive to the movements of the chest. We can use classical impedance methods. We can use acoustic sensors. I clearly have no time to describe all these methods, but I think the key message is that you need to look at validation studies, investigating the accuracy of these different sensors, because clearly they are not all made equal. Just an example with this study from the group of Korkatman, published in Anesthesiology a couple of years ago, and comparing a new adhesive patch designed to monitor respiratory rate to a reference method, and showing that, as you can see, it's not actually very accurate. Only 77% of the measurements are in the safe zones of the Clark-Error grid, that is to say the zones A and B. In contrast, these wearable, you can see that over 99% of the measurements were in the safe zones are using the same Clark-Error grid. So accuracy, of course, is very important, but obviously, a key question is to know if when implementing this new monitoring system, we can expect an improvement in patient safety. To answer that question, we don't have so many studies today, but we already have some studies. So you have here a summary of 5 studies that were published 2 years ago. Today we have 3 more studies, but you can see that these are large studies investigating the impact of continuous monitoring of vital signs on postoperative outcome, or in some studies, actually, it was also including medical patients. And you see that all these studies reported some outcome benefits, either a decrease in rescue events, a decrease in ICU transfer, a decrease in hospital length of stay. In one study coming from the UK, actually, a decrease in hospital mortality. These are very large studies. You see a huge number of patients, but these are before-after studies, implementation studies. So clearly, we don't have today randomized controlled trials to confirm the clinical benefits when implementing these kind of technologies. As I said, there are a few more studies published recently. That one was published, I think, 6 months ago in the British Journal of Anesthesia, and showing again that after the implementation of continuous wireless vital sign monitoring on the wards, they observed a significant decrease in the number of ICU admissions and a significant decrease in the number of rapid response team calls. Why that? Because when you monitor patients continuously, of course, you detect pretty early, at a pretty early stage, when they deteriorate. And sometimes, not to say very often, you can actually settle the problem before it becomes really serious and you need to call the rapid response team, or you need to transfer the patient to the ICU. So what could be available in the future? I think form factors are going to play a major role in terms of adoption. These sensors have to be easy to use, comfortable for patients, otherwise they will never be accepted. We did a survey actually last year in Europe and in the US. You see we got feedback from over 1,000 anesthesiologists from different cities in Western Europe and in the USA. And to the question which sensor would be ideal for continuous monitoring, the majority of respondents said a wrist device or a bracelet. Rings may be useful as well. And this is a recent paper published in Nature Communication describing a ring that would be able to monitor blood pressure continuously. And in the paper, they compare to a volume clamp method, which is, as you know, today a way, or possibly the reference method to measure blood pressure non-invasively and continuously today, but using pretty big monitor, definitely not a monitor designed to be used on the wards and not a wireless system. And so you see in the study, they showed a pretty good agreement between the ring prototype and the volume clamp technique. Ear sensors as well, I mean, could be interesting because ear devices are already part, I would say, of our life one way or the other. That's obviously optimal location to measure temperature, or even to measure oxygen saturation. And so we could imagine in the future to gather additional information, for example, blood pressure from an ear sensor, for instance, simply using the pulse wave transit time method. Machine learning may help us as well. So first of all, for risk stratification, I'm not sure we will need to monitor all patients continuously, all ward patients continuously. And so it would be useful to have an algorithm able to tell us that, or to identify patients at high risk of clinical deterioration. And so the idea, the concept is that when patients will be admitted, we will start to collect information that will go to the electronic medical record system. And then a machine learning algorithm will identify patients at high risk of clinical deterioration. And then we could focus on these patients, propose to these patients continuous monitoring, and other patients at low risk of deterioration, we could continue intermittent spot check as we do today. Machine learning systems may also help us to estimate blood pressure simply from a pulse oximetry waveform. This is an example of a study published in Anesthesia and Analgesia a few years ago by the group of Patrick Schottker from the University Hospital of Lausanne. And so what they did is that actually they fed a machine learning algorithm with a huge number of pulse oximetry waveforms and corresponding blood pressure measurements. And so the algorithm was able to learn to recognize specific patterns or signatures, if you prefer, observed specifically in patients who have a decrease in blood pressure or a rise in blood pressure. So they used a machine learning system, as I said, and as you can see, they tested the system or the algorithm during anesthesia induction and subsequent tracheal intubation, and were able to show a pretty good agreement or a pretty good accuracy to track changes in systolic pressure on the left-hand side or on the mean arterial pressure on the right-hand side, simply using the pulse oximetry waveform. So I think in the future, we may continue to use a Bragg curve to measure blood pressure, let's say every 5 minutes, but between two spot check, if we use a pulse oximeter at the same time, we should be able to detect any significant change in blood pressure between the two Bragg curve spot check. Another study, very recent, describing another tool. It's an upper arm sensor, but it's again based on PPG signal, so basically a pulse oximetry waveform, enabling continuous monitoring of blood pressure. So I think this is clearly happening and should be available in the next few years. So far, I described the fairy tale, everything that could be done with new technologies. Of course, there are challenges, particularly for the implementation of these new systems. In the survey I already mentioned, we asked clinicians what they think will be or should be the main implementation challenges. And number one was economic. But I think it's important to realize that if we effectively decrease the number of ICU admissions and hospital lengths of stay, it should be associated with an economic benefit as well. To be honest, there are only very few studies published so far investigating the impact of continuous monitoring on the wards on the hospital finance. This is an example, a paper published in Critical Care Medicine a few years ago, done in the US, in LA, if I remember well, and showing actually that the observed savings related, as I said, to actually a decrease in the number of ICU admission and hospital lengths of stay. And you see savings were ranging between $200 and $700 per patient with an hospital break-even observed after 6 to 9 months. So beside the clinical benefits, actually possibly some economic benefits as well. The second big challenge in the survey was connectivity, and I think it makes sense. We have all experienced disruption when using Bluetooth. And so this is an example of a study where they used a sensor using Bluetooth connectivity to transmit vital sign information. And as you can see, if for some patients it worked pretty well, so when it's green, it means, the signal was correctly transmitted to the central station. For other patients, obviously, most of the time, they had connectivity issues. So I think that's a key point as well. If you look at the different options to be available for continuous monitoring, I think it's important to choose one with a medical-grade connectivity protocol. Nurse pushback. Obviously, nurses are very concerned by the fact that if we start monitoring patients continuously on the wards, it may beep all the time. So we need smart algorithm, including machine learning algorithm, to help filter artifact and prevent as much as possible false alarms. We need to personalize alarm threshold. We need to accept to increase the annunciation delay. And these are ways to make it acceptable and ensure that it's not going to beep all the time. Last point I would like to highlight before closing this lecture. In the survey, very interestingly, most anesthesiologists thought that alarm should not be heard by the patients. And I fully agree with that. I think we need to, or we should not forget that alarms have not been designed to disturb patients and increase their level of anxiety. Alarms are for clinicians. And so we also need, and I think it's very important when you look at the different options today available on the market, it's very important to consider solutions that are able to keep quiet, to remain silent, and simply inform clinicians, nurses, first on the pager, on the smartphone at the central station, or directly the rapid response team in case of very acute deterioration, but without disturbing the patient. So in conclusion, I'm sure you agree with me, it's time to rethink the way we monitor patients on hospital wards, and particularly on surgical wards after surgery. You understood that clinical deterioration may be overlooked for hours, and it's mainly because of the intermittent nature of the surveillance today. Solutions now exist for the automatic and continuous monitoring of vital signs, and not only heart rate and respiratory rate, but also SpO2 and blood pressure. They may help to improve patient safety and satisfaction, and to decrease ICU admissions and related costs. With that, I thank you again for your invitation. Thank you very much.